So we'll talk a little bit about the JAK inhibitors for treatment of steroid-refractory GvHD. Currently, the only JAK inhibitor that is being used in graft versus host disease on a large scale is ruxolitinib, which does carry an FDA approval for therapy of steroid-refractory acute graft versus host disease based on the REACH1 and REACH2 trials. In chronic GvHD, it remains an experimental agent and is being tested in the very large randomized REACH3 trial. REACH3 is randomizing individuals with steroid-refractory chronic GvHD to either ruxolitinib or best available care at the discretion of the treating investigators. JAK inhibitors are an exciting class of compounds. They inhibit signal transduction through the JAK-STAT pathway, so multiple cytokines signal through that pathway, IL-6 and others. And so they do represent a really interesting way to treat graft versus host disease. In general, we start ruxolitinib at a dose of 5 milligrams twice daily and escalate out to 10 milligrams twice daily if the patient doesn't have dose-limiting cytopenias. There are other drugs that have been tried in chronic graft versus host disease, such as itacitinib, which was the subject of the GrAVitas trials. Unfortunately, that compound does not appear to be promising at this time in the management of chronic GvHD, although there certainly needs to be further study on that. We generally combine drugs like ruxolitinib or other second-line agents with corticosteroids for the management of steroid-refractory disease. Often the point of adding these second-line agents is to allow us to reduce the dose of corticosteroids when a patient does have a symptomatic response. Some investigators will taper steroids much earlier, even in the absence of a response, because it will reduce steroid-related side effects and comorbidity. And so there are lots of ways to do this. You can either use an additive approach or a substitution type approach, but there's no correct answer here. We certainly do all agree that if patients are having side effects from a drug, then that drug should be eliminated as quickly as possible. But caution has to be taken when eliminating ruxolitinib, as there can be a withdrawal reaction to rapid stopping of the drug. So we do recommend that this drug be weaned or tapered, even if it has to be done rapidly.